Everyone, good afternoon. Thank you for joining us today for our webinar titled From Consent to Confidence, Best Practices for Working with Youth During Their Family Planning Visits. We hope you are all doing well and staying safe. My name is Nicole Nguyen, Program Manager of the Family Planning Program at the California Prevention Training Center. The CAPTC, under contract with the California Department of Healthcare Services, Office of Family Planning, is sponsoring today's event. And then before we get started, I'd like to go over some housekeeping slides if this is your first time with us using the GoToWebinar platform. So at the top right ribbon on your screen is the control panel. There's a question icons where you can submit questions and comments, a paperclip icons where you can access any handouts that will be attached from today's webinar. The setting icon controls your audio connection preference. And then there's this 3-dot icon is how you can toggle between full screen mode and access additional settings. And then to check your audio, please click the settings icon. From there, you can select your desired setting to join either through your computer or calling in through your phone. If your internet connection is a little shaky, we highly recommend that you call in through your phone for the best possible sound. And then
we're not seeing the slides.
Oh, I'm sorry. Am I not sharing screens? Sorry about that. Oh. Here we go. Sorry about that. Is everybody see my screen now? Okay. Sorry. So let me go back there. Okay, yes. So yes, this is the little questions icon, so you can submit all the questions and comments. For our presenters, today's webinar will take about 90 minutes and will include time at the end for the presenter to answer as many of your questions as possible. This webinar will be recorded and we will send out a follow-up email with the recording and the slide deck. There is an evaluation at the end, so please fill it out because your feedback is extremely important to us and really help guide us in developing our future content. And then I want to acknowledge that we are working with the University of Nevada, Reno School of Medicine to provide CMEs for this event. This webinar will qualify for 1.5 CME credits and only available to those who watch this entire webinar live today. Those who watch the recording, unfortunately, will not be eligible for the CME credits. And the link to access your CME certificate will be included in the follow-up email along with the recording, slides, and the evaluation survey. And then for transparency, we also want to disclose that presenters, planners, and anyone in position to control the content of this CME activity have indicated neither they nor their spouse or legally recognized domestic partner has any financial relationships with commercial interests related to the content of this activity. I also want to note that although this webinar is sponsored by the Office of Family Planning and the Family Pack program, the information discussed today will not dive deep into Family Pack policies or any benefits specific to Family Pack clients. If you have questions regarding any administrative policies, benefits, or wondering if your client will qualify for Family Pack services, please send in those questions in the question box and we will answer them privately through email after this webinar ends. Okay. So now I'd like to introduce our wonderful presenters. We are really thrilled to have Sarah Nathan join us today. Sarah is a nurse practitioner at the University of California, San Francisco Adolescent and Young Adult Medicine Clinic. She is also a faculty member in the UCSF School of Nursing. She has been practicing clinically since 2008, focusing on primary and sexual and reproductive health care for adolescent and young adults. And in addition to being a clinician, she also holds a PhD in nursing with a specialization in health policy. Her research interests are pregnancy preferences, contraceptive decision-making, and clinical and policy interventions to promote sexual and reproductive autonomy for youth. Thank you so much for joining us today. And Sarah, I'll hand over the mic to you. So let me stop sharing for a second. And you should be able to share now. Yes, I see your slide.
It's gonna, just 1 second, sorry, so I can see. Sorry, just Great. Can you see that?
Yes, I can see it.
Okay, perfect. Okay, thank you so much for having me. Really appreciate it. I love speaking about adolescents and young adults. I love working with them. So I'm very excited that so many of you are here today to be able to engage in this content. Few objectives for today's talk. I'm going to differentiate between consent and confidentiality for minors, specifically in clinical settings. Apply the concepts of consent and confidentiality to sexual and reproductive health, and then identify fundamentals for care in working with this population. And I have no financial relationships to disclose. I like to frame this discussion and talks that I do on sexual health and thinking about sexual health in a broad way. I really love this quote from the WHO meeting of a group of experts. And it says, sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It's not merely the absence of disease, dysfunction, or infirmary. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. I think this is so important that we frame this in a broad way for young people, especially because this may be the first time they are accessing any kind of healthcare by themselves. And it can be a really scary thing for them. And it is part of our job as healthcare providers to be able to help them move through life and be able to access healthcare in a way that is helpful for them. So I'm going to be talking a lot about centering the young person in every clinical visit. And that means asking them what it is that they need. What are their desires? What makes them happy, and also to really help them understand what does a sexual relationship look like that is free of coercion, discrimination, and violence, because it may not be obvious to them. I like to start broad, and then we're going to get right into some of the barriers, because that's probably part of why you're here today, because there are many barriers to providing sexual health care to youth. So certainly abstinence-only sex education is a barrier. And that is to compare it to comprehensive sex education, which is what I hope that we are all going to get to after today's talk. And that really means meeting the needs of youth, understanding the range of preferences that youth have, and being able to provide them as much information as we can. Mandated parental notification in many states, this is an obligation. And that certainly puts up barriers because many youth will choose to not access care if they think that the services will not be confidential. We're really lucky in California, and I'm going to talk more about that, about there are many services that youth can receive without the involvement of parents or guardians. There are many biased healthcare professionals. We all do our best. We all are well-meaning, and we have biases, and those can come through. A lack of confidential services, certainly. So this goes back into, mandated parental notification. But confidential services, or the lack thereof, make a difference sometimes of whether or not a youth is going to engage in services or continue to engage in services. And I think a general discomfort in society with youth sexuality by adults. And this does, believe it or not, include providers too. Let's jump right in to consent and confidentiality. I want to make sure we're all on the same page in terms of what we're talking about when we say consent and confidentiality, specifically in clinical settings. So consent is a patient's ability to give informed consent. So for example, you're giving information and then the patient is choosing, whether or not they want to have a certain treatment or medical procedure. Confidentiality is what information stays between the healthcare provider and the patient. and what information can be shared with others. And federal and state statutes protect against unauthorized release of personal information. I'll begin with consent. So who can consent to care? As a general rule, minors need a caregiver to consent to care. The right of the parent or the guardian to consent to healthcare services for a minor is governed by state laws. Here in California, we have a majority of 18 years old. So when we're talking about minors, we're talking about those under 18. In California, minors can consent to care in specific situations without parental involvement. So those are these people who are under 18. There's two buckets here. One is a status exception. So that means if the minor is in the armed forces, married or divorced, emancipated officially by a court, or living apart from parents and managing their own financial affairs. If they meet any of these, a minor can consent to their own care. There are also service exceptions, and that means the type of service the youth is receiving. So for example, pregnancy-related services, contraception, STI, testing and treatment, mental health, and substance use. So in California, for all these types of services, a youth does not need a parent to consent to these services. This is a chart that basically outlines what it is that we're talking about. What are the rights of minors in California? So you can see here, the first column are the services the youth can consent to. So as I said, contraception, pregnancy, abortion, STI, treatment, sexual assault services, outpatient mental health services, and substance use treatment. And in the middle, you can see here what age. So many of these minors of any age can consent to. And then some of these are 12 and up. So minors 12 and up can consent to any of these services without parental involvement. And this other column here is about, can the provider tell a youth's parent or guardian that they have access to these services? Well, for the majority of them, no, you cannot, unless, of course, the youth says to you, I want you to involve my parent in this, contraceptive visit that we're having today. There are some situations in which a provider should attempt to contact the parent or guardian. Now, I think this is sort of ambiguous, a little bit gray area, and I think it's a little bit of a gray area on purpose because you certainly can use your own judgment. If you think as a provider that it would be inappropriate, it would put the youth at risk, then you don't need to attempt to contact a parent. Involvement in the situation does not equal parental access to the minor's records. It just means an attempt to contact the parent to maybe let them know that they have received this kind of service. But it is not that you would be able to then release the entire record of everything that you talked about in that visit for these specific types of services. And of note, for outpatient mental health services, for example, a minor can consent to these services for outpatient therapy, but if you're prescribing a medication, so a psychotropic medication, that you would need parental consent for. So there are some exceptions to these rules as well. I wanted to also provide, this is just a screenshot of the Medi-Cal minor consent services, and I have the reference right here so you can go back to it if you need it for your clinic systems. This shows the exact same thing I'm just talking about, that all of these services are eligible for minors to receive without parental consent in California, and these are called the Medi-Cal minor consent services. And you can see here also broken down by age, but just a nice reference for people who are not maybe used to doing this, or maybe need to justify this to administrations. Just a nice place to go to be able to see how lucky we are actually in California to have all of these services that minors can access without parental consent. I'm going to move now to confidentiality. These are federal and state statutes, again, that protect against unauthorized release of personal information. So some examples of federal statutes is like HIPAA, Health Insurance Portability and Accountability Act, parents have a right, they have access to the minor's health record, except when in states, for example, that have minor consent laws, a minor has accessed that type of service that falls under minor consent. So for example, if a minor is accessing contraceptive services in California, that visit should not be available to the parent. So the open health record should not be able to show everything. So that's why it's so important to have, you know, protocols in place for your electronic medical record system so that you're able to lock certain visits or make them sensitive, so that a parent, if they're asking for all of the records of their child, wouldn't be able to access everything, because the minor, again, has the right to suppress certain visits because they are able to access those services without their parents seeing them. Title X really remains in flux. There's been a lot of political back and forth. There was a 2022 ruling that recipients of Title X funding, which provide grants for many reproductive and sexual health services, are able to require parental consent depending on state laws. So again, in California, we have state laws. So this is sort of the interplay between federal and state. We have state laws that protect minors. But in states that don't have minor protection, you know, confidentiality protections for minors from these Title X clinics are really at risk under this current federal administration. As a general rule, confidentiality follows consent. So in California, a state with minor consent laws, a minor can consent for that type of service. So again, the example of contraceptive services, a provider can't break confidentiality to tell a parent about that particular service. There are, of course, exceptions. So communications between qualified professionals for coordination of care, any disclosure of child abuse, so that includes sexual abuse, sexual assault, neglect, willful harming, or endangering a child, or certainly disclosures of danger to self or others. You know, those are reasons that you are going to have to break confidentiality, even if those disclosures happen within the context of a visit that is otherwise under the minor consent laws. There's also another thing that I want to bring up, that some diseases are reportable. So in California, we have to report to the health department gonorrhea, syphilis, hepatitis, HIV. So you may want to let people know, young people know, like if you're not able to contact them and they need treatment, or if they're unreachable, then they may be visited or called by a public health worker. And in that situation, you may not be able to ensure confidentiality, or it's sort of out of your hands. So I think it's something else to bring up with young people. Important also in this category of when we sometimes have to break confidentiality is that sometimes consensual sex between two minors is actually reportable as child abuse, and all of us as mandated reporters would be required to report it. So I like this chart. It's complicated, but I think it's good if you're working with young people to have a copy of this, and please feel free to take this and put it up in your office, of when you might have to report. You can see here there's the age of the patient. So for example, you have a 12-year-old patient and they tell you they're having sex with a 14-year-old. So you can see here that that's in that orange category, the M, which is mandated report. So that would be a report. But if that 12-year-old tells you they're having sex with a 13-year-old, it's not a report. It's in this white zone. CJ means clinical judgment. You are, of course, always able to report as child abuse if you are concerned that sex in any way is coerced or involuntary. You are also not required to ask the partner's age. I think this is really important because some providers, and this is going to depend on style, but I personally don't ask the age of partners. It's also really important that before your patient starts talking, that they're really clear, and I'm going to go into this more about the exact language I use, that they're really clear about what it is that if they told you, you would have to report, so that there's no surprises, so there's no sort of breach in trust of the young person, because now they're shocked that you're having to do a report. Privacy is important for all of us. We all value our privacy. It becomes extremely important for young people early in adolescence. Youth are both striving for independence and autonomy, and this results in periods where they may be reluctant to be open with adults, or seek advice from adults. And you, as a medical provider, can provide a lot of education and information and be a sounding board for young people. And it's important that they understand sort of the confines of the relationship. So when you would have to break confidentiality. The assurance of confidentiality becomes a really important consideration for many young people when deciding to access or return for health services. So you want to make sure that you understand confidentiality rules. And if you move to another state that's not California, that you understand them so that you can explain them to your patient. It's also important, as I mentioned before, to look at your workflow in your electronic health record to make sure certain notes can be suppressed and not shared, to make sure after visit summaries are able to be edited or don't print them, so that you can make sure that you're providing care and not have to break confidentiality or have a parent see something that they shouldn't see, because the patient has a right to that information and doesn't have to share. That's why it's so wonderful to have the Family Pact program and also minor consent Medi-Cal. This is so essential for individuals, for example, with private insurance that might be, their parents might receive itemized bills that might show a chlamydia or gonorrhea test, for example. But to be able to enroll young people in Family Pact, or Medi-Cal doesn't send itemized bills, so specifically for these minor consent services, that is such a wonderful thing that we have to be able to ensure confidentiality for our patients. So what do I say? What is sort of the language I use when I'm working with young people? I say, the things that we talk about today are going to stay between us. But I have to break that and tell somebody and break confidentiality if you tell me that you are being sexually or physically abused now or in the past. You are at risk of hurting yourself or someone else. If you're under 16 and having sex with someone 21 or older. If you're under 14 and having sex with someone who is 14 years or older. Also important considerations for working with patients who are undocumented. You can imagine that patients are often concerned about disclosures because of their immigration status. And so it's very important to explain the process to patients before you make a report. It's also very important, as I said, and this is important for everybody, to outline when it is that you would have to break confidentiality so people understand before they disclose. It's very important to understand and have a relationship with law enforcement and what's happening in your specific county between federal law enforcement and local entities. So having a relationship with local police departments so that you can explain to your patient, if you do have to do a report, what is going to happen. And giving patients the opportunity to tell you as much or as little as they want is important for all patients. You are going to explain in the situation where you do have to do a mandated report that you have to do it and why. And you are going to inform people that they have some control here. You've taken away some control for sure, but you can give back some by saying that patients can tell you as much or as little as they want. And that is what you're going to put in your report. This is a sign that we have in our waiting rooms, in the bathrooms, in clinic rooms. It's from Adolescent Health Working Group. Feel free to take it and distribute it. It basically just uses the exact language that I said, and somebody can be waiting for you in a room and staring at it, and so that they can understand what it is that the confines of the relationship. So what will stay confidential and what won't, because it's really important to talk about this often. So when I'm seeing patients who are under 18, it's not just the first time I meet them. You know, we want to review confidentiality at a lot of different visits to make sure that people understand when it is that I would have to break confidentiality. Now that we have an understanding of some of the basic principles of consent and confidentiality in California, I want to move into some of the important things that I think about when I'm working with young people. I think the communications and interactions should be tailored to youth developmental stage. Now, there is not one developmental stage for every person. Everybody is different. Everybody has different realities, different experiences, and that's going to change how they may present or their needs, of course. I think this is just guidelines that can just serve as a place to start, especially if you're not used to seeing young people in your practice. I like to think about adolescent developmental stages because then you sort of have some idea about the person that is in front of you and the way maybe that you might change your communication tactics. So early adolescence, really a lot of emerging identity, peers are very important. You know, so asking about what your peers are doing is very appropriate because that can give you some idea maybe about what the youth is engaging in as well. There's a lot of gains in height and weight. There's certainly limit testing. It's important to be concrete and again, focus on the youth's concerns, really put the youth in the center of this visit and find out from them what it is that they want. Middle adolescence, there's more reasoning about emotions and also emphasizing adult connections, finding out from a young person, you know, maybe it's not a parent or guardian, but maybe it is an aunt or an uncle or a person at school that really is in that young person's life and is giving them advice or they are able to go to for information. Late adolescence, people are often able to really think more abstract reasoning, thinking about transition planning, concerned about partners or future relationships. And so you can engage more in a, you know, so how would this impact, you know, what it is that you want to be doing in 5 years? And they're really able to engage in sort of more of that future planning. Person-centered counseling is essential, in my opinion, for all of us and every single visit we do, no matter the age of the patient, but especially important, as I've talked about, with young people, because young people are constantly being told what to do. They're being told by their parents, by their teachers, they're being told by society that they are risk takers, that they are dangerous, that people should not want to work with them. And it gives them an opportunity, if you are able to really get from the person in front of you what it is, what are their goals, what are their desires, what is it that they want out of this visit. I do a lot of normalizing. So I think I say, oh, I have a lot of patients that tell me, you know, blah, 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 because I think that that helps the young person think, wow, I'm not the only one dealing with this. And that can be really important because, again, this might be the first time they're accessing healthcare by themselves. This might be the first time they're bringing up this really sensitive, vulnerable issue for them. Positive steps and successes should be acknowledged, again, because so much of a young person's life could be the world telling them that they're doing the wrong thing, or they're taking risks, or they're, you know, using too many substances or not doing well enough in school. And so there's a lot of pressure there. So taking something from what you're hearing the youth tell you and acknowledge it and say out loud, wow, it sounds like you're really working on this and you're making such progress. Every interaction is really an opportunity because it can be really hard for young people to get in front of us. And so make sure that if they do, you're able to offer a range of services, and that if you don't know the answer and you're not the right one to be handling it, that you have resources so that you can give them something before they leave. Using open-ended questions, again, this is just important for all of us, but don't close down the conversation. Be curious, be open. And again, this referrals, having referrals for emotional, behavioral health, well-being, so that the young person, even if they're accessing physical health care from you, that you're able to give them resources, for whatever else it is that they need. In our clinic, we're really lucky. Social work is available for warm handoffs. They're part of our team. And I do think that that is a huge part of adolescent and young adult medicine, is that team approach, being able to connect young people, because their medical issue may be a small part of what it is that they need. They may need housing resources, food resources, etc. The discussion of the parameters of your relationship, again, should be done not just once, but in multiple occasions. And not just talking about confidentiality, of course, that's a really important one, but also cost, if there's any. If there's co-pays, that young people are not surprised, that's going to help them feel like they can trust you and ask questions and want to come back and see you and engage in care. I am just a huge believer in this last one, like, believe youth within reason. It doesn't hurt you to just believe someone, or look like you believe somebody, even if inside you're like, this is a ridiculous thing that somebody is saying to me. Believe youth, because it gives a message that you are invested and that you are centering this person in their care and you really are taking them seriously. So I encourage you to try this. A really important part of being able to provide what I think is comprehensive care to young people is separating them from the adults in their life. So many of us work in clinics where we do primary care, which is what I do. And so that can include everything that a young person may need. So a youth might be coming to you, for example, for a physical exam or for a visit for their asthma, and they may also want to talk to you alone or need to talk to you alone about sensitive issues. So for the physical exams, for example, these are longer appointments for us, so this is really easy to do. It's really important to make that a priority in your clinic and think about how you can separate young people. You want to lay out the course of the visit. So you're going to have the youth, their parent together. We're going to start all together. Then parent, I'm going to meet with the youth alone. You can sit in the waiting room, and then I'm going to bring you back. You are not singling out their child. This is what we do for every single visit. This is our program policy. And you're going to acknowledge that we know that your youth is a minor, and here in California, they have certain rights. And that means that we are going to review consent and confidentiality and explain to the parent that there are situations in which you are going to break confidentiality. So that reassure the parent or the guardian that if your child discloses that they would like to harm themselves, then you can and you will discuss it, and you are going to break confidentiality. And then finally, thanking the parent for being there. Really validate that they are here. It is challenging as a parent sometimes to feel like you are losing some control. You want to thank that parent for being invested in their child's healthcare, or that guardian, or whoever is there with that young person. And you also want to say that it is equally important that youth have autonomy. And so you're gonna appreciate both in this visit. When you have the youth alone for the portion of the visit where maybe you're going to do the exam and you're going to talk to the young person, you can encourage youth to discuss issues of sexual health with their parent. And I do this because we know that it is really valuable to have an adult in your life that you can talk to about things. Of course, only if this is appropriate. There's a lot of different individual circumstances that would make this not appropriate. You can help explore approaches the youth might take to be able to have this conversation. How do they imagine this conversation would go? You can offer support, tools, and you can offer to facilitate. I often do this. Or I say, would it be helpful if when we bring your parent back, we all talk about this? Of course, you need to get the consent of the minor to say, hey, we've just decided that you'd like to start, a contraceptive method today. Would you like help in talking to your parent about that? And maybe the answer is no, but that's something that you can offer, because that facilitation models how they can have these more difficult conversations with the adults in their life. Specifically, I also want to touch on sexual and reproductive approaches, or approaches to working with people in the area of sexual health, because that is a lot of what we do when we're working with young people. First off, as I started this whole presentation, let's think about sexual health in a really broad, positive way. So sexual exploration with yourself, with others, is part of a normal, healthy development. And we want to make sure that young people understand that, adults understand that, so that we are not creating an environment of shame, of people feeling that they can't share things. Of course, these are all really vulnerable places. These are things that are very difficult to talk about often. And if we approach it as that this is normal and healthy and a part of development, that can really help people to think, maybe not on today's visit, but maybe in a couple of months when I've met you a couple of times, I'm going to feel comfortable talking to you about this. Discussing that we all deserve relationships, sexual or not, that are free of coercion and violence. And then, as I talked about earlier, talking about what that looks like and what that means. And refraining from making assumptions. We all are going to make mistakes, but keeping things broad. So when asking about the types of sex, so what are the body parts someone is using, right? Or they are interested in using. And so what body parts are touching what body parts, or what body parts are entering what body parts? And it's not because, we're nosy, but really explaining to people the reason that I'm asking you these questions is because I want to understand, where we should be testing, for example, for STIs, like where we should be swabbing, because where are you at risk to have potentially gotten a sexually transmitted infection, or are you having a type of sex that would put you at risk for pregnancy, right? And so we just want to let people know that we're curious and we are keeping an open mind, and we are trying to figure out and help best support them in terms of keeping them healthy. Reproductive autonomy is a huge topic. I'm going to briefly touch on it. I think it is really important, and I am happy to talk more about it in the questions. It's so important. I think that over the years, there's been so many, well-meaning clinical interventions and public health initiatives that really have focused on pregnancy prevention for young people. And the way that we prevent pregnancy among young people is we promote contraceptive use, and that all youth, we should be working towards getting all youth to be using contraception or to be not getting pregnant. No, but we know that some youth want to be pregnant. Some youth are ambivalent, undecided, or maybe fatalistic about the possibility of becoming pregnant. And interventions that promote contraceptive use as the end game, as the only focus, really undermine the autonomy for young people and also perpetuate a mistrust in the medical system. So if a young person feels like you as a provider are only going to be preaching about IUDs, then that may make them not want to show up. And so all of this to say that it's really important to respect sexual and reproductive autonomy in young people, just like we do with adults. But I think that sometimes we forget that extra step of that we're talking about reproductive autonomy, and that is equally important in young people. There are a range of preferences that young people have around the way they want to have sex, who they want to have sex with, whether they want to be pregnant, whether they don't want to be pregnant, how they want to prevent that pregnancy. Specifically when assessing a need for contraception, because I think this comes up a lot in working with young people, there are a lot of approaches here. I like asking a direct question. Just as simple as, what are your needs, if any, regarding a contraceptive method? There are a lot of tools. There are some scripted tools like One Key Question, and that's about, would you like to become pregnant in the next year? Or the self-identified need for contraception. You might want to play around with this if you are not as comfortable talking about the subject with teens and you kind of want a script. But I like being direct because I think that if you're just asking about pregnancy intention, that's complicated because some people may not know how to answer that question. They may not know if they want to be pregnant. They may want to prevent pregnancy now, but then in a few months, they might want to consider pregnancy. So I think some of these, one key question or one question can be a little limited. You can just let the patient dictate if they need and want additional information, which is why I like to kind of go to the direct question first. And again, there's not a right or wrong if you like the key question, if you like other tools, but allowing the patient to really dictate if they need or want additional information. And then also making sure that patients know about non-contraceptive benefits of methods. So somebody might not even be having a type of sex that puts them at a risk to become pregnant, but they might benefit from a contraceptive method that, for example, would decrease heavy menstrual bleeding. So we shouldn't make assumptions that young people know about this. And if a patient does desire a contraceptive method, asking about the priority feature in a method to help guide counseling. Some people, that priority might be that it is the most effective method possible and it lasts the longest, right? Other people, their most priority feature may be that they want to be able to insert it by themselves. Like they want to be able to put the ring in and out. They want to be able to take a pill every day. They want to make sure they get a period every month. They never want a period again for their whole life, right? Like there is a huge range of priorities. And there's not a perfect method. And the method someone chooses will not be perfect. And we can, trial and error. So I think that this is a place that you can experiment with people, but really allowing them, again, to tell you what it is that they prioritize in a method. All right. I wanted to, at the end here, get into some cases. I know we're a really big group, but I think these cases can just allow us to have a little bit of a discussion, and you put some of your reactions, some of your thoughts in the chat, and Nicole is gonna help me and read them out so we can sort of move this along in a way that we can sort of integrate some of the things that we've been talking about in order to think about the best practices in adolescent and young adult health and how we might approach these patients. There's no wrong answers, of course, but RH, she, her, is a 16-year-old requesting a pregnancy test. She's been trying to get pregnant, has not used any contraceptive method in a year, and would like tests ordered to see if there's something wrong with her. So I think just, first reactions to this case. What comes to mind here for you?
I'm waiting to see if the comments are coming in.
Yeah, thank you.
And please put them in the questions. Oh, so here's some. Okay, so why are you trying to get pregnant, to be honest? Is her period regular? Why does she want to be pregnant? Does she have regular sex? Is someone pressuring her to become pregnant? What is her motivation to get pregnant? What is she thinking? And let's see. I would tell her it's very common to take a year or more to become pregnant, but let's talk about why you are seeking pregnancy. Are you having any regular periods? Are you tracking your periods? Do you know about ovulation? Can we talk about timing of contraception?
Yeah, great. So I think we all probably have some kind of reaction to this. And it's important to understand what your reaction is. And once you do that, I would encourage all of you to exactly be curious, ask questions. Tell me a little bit about how you've been trying to get pregnant, or how often are you having sex? What makes you think there's something wrong with you? Like getting more information and all that, and being curious, and allowing this patient to have some opportunity to talk about what this would mean to her, and where she is in the process of thinking about how this would impact her life of pregnancy. And again, people are just have a lot of different ideas and thoughts around being pregnant. And it might be an initial reaction that this person is too young. It's not going to be great if she gets pregnant. It's not, and we don't know what her story is. So allowing her to give us some of that is helpful. But I love these ideas of all these questions that you can ask her. Okay, JM, they, them, 16-year-old, is in clinic today with their mother. Visit to discuss heavy, painful periods. After discussing the options to decrease menstrual bleeding, JM's mother is very clear that she doesn't want JM to use hormonal contraceptives. When you speak with JM alone, they disclose they would like to be on a contraceptive method because they're having sex with someone with a penis and do not desire pregnancy. They've heard a lot about the IUD and want to know more. So what do you think here? Where would you start with this case?
Seeing some comments in who is a safe adult that you can speak to about safe sex, talking about confidentiality. I would make arrangements with JM to obtain an IUD at a visit without their mother. Let's see. What have you heard about the IUD, and what do you like about it? And depending on the age of consent in the state, should consider a confidential visit for the patient. Let's start with what you have heard or what you know, and then tell them more about it. Why does mom have concerns about hormones? Informing JM about their rights and ability to get an IUD, confidentiality, and if they want to. And then offering benefits and complications of the IUD. What other menstrual symptoms are you having? And education about various methods of birth control. Supporting the decision and providing information, and schedule a visit without the parent for placement.
Yeah, great. So really important here. This is why it's so important to be able to talk to JM alone in this scenario, right? Because you might have missed half the thing here if you only went into the visit and talked about just the heavy, painful periods with mom in the room. I think, yes, validating mom, what are your concerns? What are you concerned about with the hormones? And then talking to JM alone and talking about the IUD and getting all that information, what it is that you're really interested about the IUD, what makes you really like it, and then, yeah, getting that person another appointment. The best time to get an IUD, and we try to do this as much as possible in my clinic, if it is okay with the young person, is to be able to do the IUD, then and there, to be able to provide contraceptive methods when the person is asking for them, if that's possible. But you want to, strategize this with JM. If like an IUD appointment cannot be done quickly, most likely this would have to be set up as another appointment, right? And depending on the insurance, if they have private insurance, then you'd have to get them on a minor consent Medi-Cal or family pack for that next visit. So that might be the case, that this has to be another visit. Another thing too is talking to JM, be like, hey JM, one of the indications for example, a Mirena IUD is decreasing, heavy painful period. So if you want, we can go talk to mom about an IUD as a method for decreasing this as well, right? And that maybe there's a slightly lower hormonal content than the pill, for example, right? So you don't have to then disclose to mom every single reason why an IUD might be a benefit, right? So you're able to still protect some confidentiality unless JAM feels like they do want to disclose. So there's a lot of ways to go, but I really appreciate all of your comments about thinking through the way that this could go. And again, it's really nice in clinics where you can have a system where you can enroll patients in another type of insurance that gives them that confidentiality. Because for some private insurances, a parent might get like an itemized list of, for example, like that a birth control pill was prescribed or the IUD procedure was done. So it is really important to be able to offer confidential services to young people. And this is a pretty common scenario, this last case, so many of you may have seen this in your clinics. RF, she, her, is a 16-year-old. You've seen this patient for primary care in your clinic accompanied by her mother. You've also seen her subsequent visits and prescribed her oral contraceptive pills. Because, just as an aside, many young people will choose to come to your clinic with their parent for some types of visits and then very clearly come for these minor consent service visits by themselves. And that's totally appropriate, right? Her mother found a pill pack in her backpack. Mother called the clinic upset that the provider had prescribed this medication to her daughter without asking for parental permission. So what do you do in this situation? How would you handle this? And have you done anything wrong? It might be another thought.
Too bad, Mom. Sorry, not sorry. This is something your daughter can get under the law without permission. Describe patient's right and confidentiality. Let's see what else. Asking for any cultural issues. See, cannot acknowledge that patients was ever seen. Educate parents on confidentiality rights that minors have. Praising her daughter for being responsible.
Yeah, so these are great. Thank you. Yeah, you haven't done anything wrong because, you haven't disclosed this to the parent because under laws in California, this is a service that RF can consent to without parental involvement. And in fact, you, the provider, would be at fault if you had done so without the permission of this young person. When you are prescribing, for example, pills, because it's harder to hide these in a sense, like you can talk through with a young person. I think it's a really good idea to think through the scenarios. Like, how angry would your parent be if they found these pills, or your guardian? How angry would they be if they found these, right? Oh, super angry. Okay. Wow. Can you keep these in a place where your parent doesn't look? Like a backpack might not be the best place, right? And so are there places that you can think about in your life that they could be more hidden? So you can help a young person work through some of these scenarios because you know that this is possible. And these are difficult situations. I mean, I think you do want to let the parent know that, I understand your concern, and my job as a healthcare provider in California is to help also protect the rights of your child. And part of that is respecting the laws of minor consent. So, um, you know, I think this is a challenging thing for parents if they are not aware of minor consent. That's why it's so helpful to be able to go through these things if you can with, when young people are coming to your clinic for the first time, or at physical exams that might happen annually, when you think that maybe a parent would be there, talking about these things. And that doesn't mean that it will fix it and that parents still may not get angry because they might forget that you have this conversation, but you can try. Great. Overall, clinical policy takeaways, I mean, there's so many, but I hope that you have some understanding right now of consent and confidentiality laws here in California. And I encourage you to think about promoting sexual and reproductive autonomy wherever you can. And that's really by engaging in how to provide resources to young people and helping them to get their needs met, get their preferences met. So maybe that's avoiding pregnancy, or maybe that's becoming pregnant, or maybe that's understanding their contraceptive need, or understanding their need around sexual health, or different types of treatments, or where they're at. And really allowing young people to have some autonomy in this sphere. Promoting sexuality as a natural, healthy part of development for everyone. Sexual health is not just the absence of disease. We really want to think about it in a positive light. There are a range of preferences around sexual health, identity, the behaviors, the actions, everything. There's a huge range. And we may not even understand all the things on that range. And so we can ask our patients too, to help us better understand if that's what is needed. Centering the patient always in the interaction, allowing them to drive the interaction as much as we can. And allowing youth to design programs and clinical services. I think having youth advisory boards in clinics, or having opportunities to be able to talk to our young patients about what it is that we could be doing that helps get their needs met better. Every once in a while, if you have a clinic that sees a lot of young people, finding ways to meet their needs better by changing your policies in your clinic or designing the hours differently. I mean, in the range of possible. But I think that is a great exercise to be able to engage young people. And again, they may not have ever been asked for their opinions here. And so this really sets them up for a lifelong journey in navigating healthcare. So what a wonderful thing to be able to do, in my opinion, as a healthcare provider, is to start them off on that healthcare journey in a positive light that takes into account, their thoughts and feelings. And a part of that, right, is expanding contraceptive access. And again, we are very lucky in California, but for those who desire a method, and breaking down clinical systems and allowing for, potentially same day insertions of methods if that's what is needed and desired by the young person. So here's some references, and you'll get these slides. I really look forward to the questions, and if we don't get to all of them, you can feel free to email me. But this has been really great. So I look forward to having a discussion with you.
So yes, I think there's some questions coming in already.
Yeah.
We've assigned them to you, so go ahead and start. And then please continue to send the questions in, and Sarah will try to get to as many of them as she can.
Yeah, so a question about chaperone use for sensitive exams procedures. Should 12 and up be allowed to decline a chaperone with the parent's knowledge? If it's in the context of a type of visit where that needs a procedure, right? Like if it is a concern for a sexually transmitted infection, and that's what the purpose of the exam would be for, and so the patient should be able to say what they need for that visit. What if the parent refuses to step out of the room? This is really challenging, and this does happen. And I think just going back to the idea of this is a clinic policy. So we do this with all patients. We are not singling out your child. It is clinic policy for every single minor at this clinic to be able to have time alone with the provider. And so we hope that that would work. And then sometimes you have to escalate this if a parent is really refusing to step out. But I do think that for the most part, if we can explain to parents and talk about minor consent and the laws, then I think that a lot of people will appreciate that. I know laws are different state to state. How do you suggest handling an adolescent who wants to keep it confidential from their parent in a state where it is not allowed? So yeah, I mean, I guess I'm not exactly sure what thing, but if for example, it's like anything in the like sexual health realm, if this is talking about like the birth control pills, this is really challenging. That's why we are so lucky in California. I think that the more you can strategize with the patient, if you can be with them alone for a little while, of like, okay, we are going to prescribe you birth control pills. That's what you want. Would it be okay if we had a conversation with your parent about other reasons to prescribe this medication that are not about sex? So that could be a way to say like, hey, there's all of these non-contraceptive benefits, for example. I mean, the contraceptive one is a little bit easier, right? Because there are non-contraceptive benefits. And so can we strategize? Can we talk with your parent? And we don't have to disclose the sex, but we can talk about this as a health concern you're having because of your heavy periods, and can that be a reason why you're getting it? Otherwise it's just really difficult. I mean, this is why I'm so concerned about the current situation, because this is that a lot of adolescents are going to have to choose, and they are not going to be able to, or they're not going to get services because they are fearful about if it's going to be confidential or not. How would you respond if a minor wants their parent to remain with them at all times? Yeah, I think, again, it's the minor that gets to decide, right? I would definitely have a minute with the parent out of the room to ask that question. And then if the minor's like, look, like I want my parent to be in the room, then just asking them to making sure that they understand the types of questions maybe that you're going to be asking, because I think that maybe that may not be as clear. So I think that is always something that can come up. Is there any specific directive for unaccompanied youth? I'm not sure exactly. Unaccompanied youth, so if they come to the clinic by themselves, and or if there's unaccompanied youth in the country, because their parents are in other countries and they're living here. This used to come up a lot in the clinic that I worked at before. If there are, who's ever the guardian for that person, they are the ones that are, being able to direct care. So even if there's not a formal guardianship, but who's ever taken responsibility for that person who they're living with, then that's the person that would be under the eyes of the law in California. Besides developing open communication, how to approach birth control methods with a teen mom who is not interested. So a teenager who is a mother, that's how I'm understanding it, or the mother of a teen. So we can go either way with that. But so if the mother of the teenager is not interested in birth control methods for their child, but their child is, certainly here, then you can try to figure out a way with the young person to be able to prescribe or be able to, provide a method that that is be able to hidden from the parent. But I think for a person who is a teen mother who's not interested in birth control, so maybe a teenager who already has a child, and maybe you're thinking about for prevention in the future. Again, if somebody is not interested in birth control, they're not interested in birth control. I think being able to provide information, asking the questions about what it is that they're concerned about using, and thinking about, what would another pregnancy mean for you in your life? I think so that is really important to be able to think about that, and from their perspective, like how would they deal with that? So are there best practices for documenting in the EHR? Teen versus parent contact information, B, heads type assessment that have confidential info but are within a more general well child check? Yeah, it's a great question. You can we use Epic in my clinic, 2 different notes. So we have a note, the note, whatever the general note that you did today, and then you can open up a second note, and there are, and I assume this is the case for other systems that are not Epic, like we can lock a note. So you can have multiple notes for the visit, right? So one of them is just the general note. The second note, you can choose to lock it. So basically, and there's a bunch of different reasons. One of them is because the person is between 12 and 17, and for confidentiality reasons, you're locking it. So then basically it's a suppressed note so that the adult does not have access to it. And so that is what you can do. So we chart whatever we want in that note. And you can have templates for, sexual, reproductive health, sensitive service notes. And that way you can suppress that information. You want to make sure that your AVS, your after visit summary, also, you can also, in certain systems, the best practice would be to have it be complete AVS or not complete. You don't want to do a complete one because maybe you've ordered chlamydia gonorrhea testing because of the conversation you've had with them in that sensitive visit, part of the visit. So you want to be able to look at your system. So there's not a best practice because I know every system is so different, but I think that it's worth it. I guess a long answer to say that it's very much worth it to work with the people in your agency that are on the back end in terms of IT and are able to troubleshoot and say like, hey, like we want to accomplish this. How would we do it? And the overarching thing is that you want to be able to make sure that parents don't have access to certain types of information that fall under minor consent in California. Just trying to see what we've gone through. How do you handle consent with an adolescent with neurodevelopmental, disorder or intellectual disability? Great question, very complicated. And there's such a range for neurodevelopmental disorders and intellectual disability. Like certainly if somebody is conserved, then they don't have the same consent abilities and rights. So I think it's understanding the individual patient in front of you. But in many situations, you might have to talk with the patient alone first to be able to understand, where they are in sort of the spectrum and how much you think that they understand. But certainly, people do have a right to having confidentiality. When you say sometimes you need to escalate this, can you discuss what that might look like? RE, a parent refusing to leave the room. You might need to get your clinic manager involved. So sometimes as clinicians, like we do need to work in the context of larger systems. So you have managers, administrative people who are available to say like, yes, this is our clinic policy. And this is why, so that you are not the only person, not the only lone voice in this, that it is a system effort. Even though RH care can be consented to as a minor, would it still be recommended to explain mandatory reporting laws to the youth when you have their first visit? Yes, I think, again, it's always really important to be able to explain to the young person that under these certain, these are the certain services that reproductive health care can be consented to. These are the, and there are mandatory reporting laws, especially around the issue, I think, for consensual sex between two young people. They may not think about that as an issue because for them, they're having consensual sex. But because you're a mandated reporter, that might change things if they do disclose, for example, the age of their partner. So I think, as I said, I like having things in clinic, not just my voice, but also pamphlets hanging on the walls, systems like that, to be able to have people understand that there are exceptions to the confidentiality, especially around disclosures of abuse, self-harm, etc. So that, again, it's not a surprise. Any advice for when a provider orders blood work for RPR and HIV and parent question the order? Parents usually will see it when we give lab slips to them at blood draw in office or blood draw in office. Yeah, this is the big issue. So this is about clinic policies and workflows and in your EHR, right? So if, for example, somebody has private insurance, then often with private insurance, like there is itemized list of things that were ordered. Or for example, or if you are just giving them a lab slip or you're drawing the blood in the office, then it might be easy for a parent, if they're with that young person, So that may not be the best workflow if it is very important for that young person, for their parent to not know that they're getting an HIV test, for example, or a syphilis test. You can give the patient, for example, family pact or Medi-Cal minor consent, and then order those labs under that insurance, right? You have to create another encounter for the visit that day, or you can tell the patient to come back on another day, right? And because they'd be able to see you by themselves, or thinking about, how to not give a lab slip or not give an AVS, right? And these are all like depending on where you're working and how it works. If it's just like an electronic system that is transmitting, the lab orders, or if it's actual paper. But I think certainly making sure that you understand what it looks like when you print out an AVS. Sometimes there's like policies just like handing an AVS to the family at the end of the visit. Maybe you don't do that. Maybe AVSs is not going to be the thing for your clinic, or you can have certain AVSs that are designed to not print out everything. But I think working through these systems and then telling a young person, like, is this important to be unknown from your parent, right? Like, is it super important that your parent does not know that you're getting this kind of blood draw? There's other ways to just say, like, look, like, every single person in our clinic gets a test for chlamydia, gonorrhea who's above 15, right? Like, you can also do that. And that's possible. So you kind of have to work with your own clinic system. This is kind of related to when a provider orders lab screening for STIs, a summary of the visit will show the orders, including diagnosis. Usually parent will ask for a copy of the summary. What should we do in that case? So you can just not put that as again, you can change the AVS, right? To limit, to not say, to like pick and choose what your AVS prints is what I'm trying to say. You cannot put a diagnosis called STI screening. You could put like due for screening or something like that if you wanted to at least have like a summary of the diagnoses, but maybe not the tests that were ordered. So I think you have to work within your systems to be able to find a way to be able to do this. Again, creating a separate encounter where, and under that encounter is where you order all of the labs for that day that are maybe STI testing. So you can be creative and really working with your IT team to be able to tailor what it is that you need, like say what it is that the goal, which is to be able to protect the confidentiality of young people. And then really importantly within the visit, once you understand what your system is capable of, to really making sure that a young person knows what might happen, right? And so if I say like, hey, you want, birth control pills today, I can prescribe them and you have private insurance. So if I prescribe them, like it's possible that this is going to go on your parents, summary of medications for this month, whatever. How big of a deal is that? Is that, and then you can kind of work with the young person, and same thing with ordering labs. Oh, an AVS, so an after visit summary. So that's what I'm referring to when I say the AVS. And so that is just sort of a printout of the summary of the visit. And for many systems, it's just going to automatically take every single one of your visit diagnoses and the tests that you've ordered. But you can, be able to tailor that. A question here, not sure if I missed it. What about foster children in terms of whoever is the guardian? So if it is a foster parent, that person is the one that can give consent for the duration. So different people in foster care are under different situations, but the person that has been designated to be the is the person that can give consent. Everything still applies, though, that young people are still able to consent for the specific services. Now, separate from foster care is a whole other situation that I briefly mentioned about a court you can go through a formal process and become emancipated as a youth, as a minor. And so somebody may have gone through that process. And then again, and there's like a further sort of even more gray area, for example, unhoused youth may not be living anywhere near a parent, don't have any contact with a parent. In those kind of situations, it's a gray area. We don't want to withhold care. The young people would be able to consent for their own care too, even for situations that are not specifically mandated under the minor consent. These are all great questions. A note, should our note of documenting a CPS report be made confidential in the patient's chart? Or should the patient have access knowing should the patient have access to it knowing they request their medical records? I think I'm understanding, but if you're doing a CPS report, you would want it to be, it's not going to be confidential, right? Like, so you're telling somebody that you're doing it. And both for the parent and the young person. And so it wouldn't be confidential because somebody is going to be reaching out. And it depends in, your county, whether also law enforcement is going to get involved. We have a few more minutes. Seeing if I've answered everything.
Hi, sorry, I think I can help too. Some questions.
Yeah, sorry. I mistakenly didn't X them as I started answering them, or like get rid of them from the board. But
one of the question is, what if the patient's mother comes into the clinic with a referral and wants to know what is the referral for and why?
I may not be exactly understanding, like a referral to what? I mean, it's like so it depends. Like if it's a referral from like an outside person to your clinic, and you're going to be dealing with like sexual reproductive issues, I think you can't disclose anything until you've talked to the young person to see what it is that they want. So it's like if you're being referred to talk about contraceptive methods because a person is having sex, but then you would need to make sure with the young person that you understood. That's a perfect situation that you could talk to the healthcare provider that referred it to you first. Like, and that's a great thing, is that you can always talk to other healthcare providers. That's not breaking confidentiality. So I'm sorry if I'm not quite understanding the referral part, but if it's like a referral, for example, from you to someone else for like mental health, you would want to understand again your medical systems, where you would want to be able to like suppress that referral so that it wasn't known to the parent. I'm thinking about like if you're referring for therapy for a young person, they don't want their parent to know. In that situation, though, really you are required to inform the parent that you are making a referral for mental health care. So it really just depends on the type of situation, and also the type of insurance they have, right? Like, so Medi-Cal insurance is really nice because it doesn't give itemized lists of all the things that you're doing in the visit. How do you handle it when a parent insists a minor get on birth control and that minor doesn't want it? It actually happens a lot here. We typically try to come to an agreement with both parties, but it's tricky, especially if the minor is sexually active. Yeah, that sounds challenging. I don't believe in providing care for in that way, right? Because it's something that the minor would have to do, right? Like maybe they'd have to take a pill every day, they'd have to put a patch on them, an IUD insertion. Like I'm not doing a procedure, for example, on somebody who doesn't give permission, right? And especially about this birth control, like these are services that a minor can consent to on their own. And so therefore, I know this is complicated, and it would involve, you know, talking to everybody. But I think that we can't force our minor patients to be put on birth control. It's really difficult, and I know this conversation can be really difficult, and I just wouldn't feel right forcing somebody to do this if it's not something that they wanted. And that just goes against sort of the principles of autonomy. I know this is really difficult, and in the end, like you can only advise what you're going to advise. But you know, I don't think we should be forcing people into using contraception if they don't want to. You know, typically you say that we can come to an agreement, and I think that like understanding both sides of it and making sure that you have time alone with the young person is going to be really important in these situations, and having time with both the parent and the child together, because the young person is your patient, and so that's really where the obligation lies.
Oh, okay. Another question was, at what age are we testing teens for STIs? Is there an age different for males versus females?
So like in the, you know, in terms of like the consent for being able to do STI testing is 12 and up. And so I think it just depends on a risk profile in terms of like the type of sex that the person is having, who they're having sex with, partners, how many partners, and you know, just the way that somebody is having sex, or if they're having sex, and the type of sex they're having with who, is the way that we think about testing. But certainly anybody 12 and up is eligible to receive STI testing. There are, so there, you know, there's, I also, just quickly, like the CDC STI treatment guidelines go into like much further detail, but it's nice because it will often have like a little section on adolescents too, and considerations, which I think is great. But thank you so much. I really, really appreciate all this, these questions, and thank you.
Yes, and then I just want to answer one last question. The question was, do you have any good website or online resources you can give to early adolescents about sexual anatomy and other health topics? So I just want to share that for the Family Pack program, we have a bunch of new client education material. So that's been redesigned with 5th grade level reading in mind. So there's ones all about the pills, all about the patch, the ring, all the different birth control contraceptives that you can use to share with your clinic. They're both available in English and Spanish. And then Sarah, do you know of any other websites or online resources to give?
Bedsider.org is a really great one. And they now have a Bedsider Plus for providers. So with a lot of like patient-facing information too. So put a plug in for that. And that's a great resource as well. And then of course, you know, Planned Parenthoods also have a lot of great outward-facing patient information about sexual and reproductive health.
Wonderful. Yes. So I'm just going to pop that last link in so that we can share that as well. And then, sorry. There you go. And then for bedsiders, I have that as well.
Yeah, bedsider.org, I believe. Yeah.
Which is really fun. That has always been, I used to use that when I was a teen in college, trying to navigate sexual health and everything. So put that.
Yeah, there's just a lot around it. Kind of, there's some, I think, excitement around being able to provide, resources to young people, especially in states where there's more restriction. So I think that doing what we can to be able to give people these resources is really really important. There's also another plug, the UCSF reproductive health hotline, and that's just for providers. But I welcome, that's a really great, that's new, and it's sort of any provider questions about sexual reproductive health is really great as well. Oh, great. Yeah, that's their website. And it's a free resource for any providers, not for patients, but for providers. So you can ask your questions. And I think that's a great resource as well.
Yeah, so I think that's about it. I know we're right on time. That concludes our webinar. Thank you, Sarah, so much for this wonderful, wonderful presentation. It's been awesome. And so I just want to remind everyone, we will send out all the information, the slides, the evaluation, and your CME link in about 4 weeks with everything in it. And then there'll be an evaluation that comes up right after this webinar ends. So please fill that out to give us feedback. And then again, I want to thank you, Sarah, for such a wonderful presentation. And I hope you all enjoy it and have a great rest of your week. Thank you so much. And thank you, Sarah. This is awesome.
Thank you. It's a pleasure. Thank you so much for the opportunity.